and thank you.
Recording in progress.
Hello, and thank you for joining us today. Welcome to NOCC's Ask the Experts. Today, we will be discussing what's happening right now in the field of ovarian cancer research and answer some of your questions that have come in. The National Ovarian Cancer Coalition is dedicated to providing education to the community in an effort to increase awareness of the disease and to also improve quality of life. So we're so thankful for the researchers in the medical community who dedicate themselves to improve the outcomes from this disease and that are providing hope to our ovarian cancer community. And we're so grateful today for our expert panel for being with us. Joining us today are Dr. Chu from Fox Chase Cancer Center in Philadelphia, Pennsylvania, Dr. Villela from Northwell Health in New York, and Dr. Richardson, who is Vice Chair of our Medical and Scientific Advisory Board, and also from the OU Health Sciences Stevenson Cancer Center in Oklahoma City. So welcome to all of you, and thank you for joining us today. So we're going to go ahead and get started. And I'd like to start off by Dr. Villela. Let's start with you and maybe talk about one of the hotter issues that's kind of being talked about right now around HIPEC. And maybe some molecular characteristics around that. So let me go ahead and turn that over to you. What's going on in the world of HIPEC right now?
Hi, thank you for having me. It's nice to be with my esteemed colleagues and with the National Ovarian Cancer Coalition, which is just an amazing organization, and I thank you for the opportunity. So, HIPEC has been, it's an old topic. It's kind of a topic used in other diseases and has recently had some promise in ovarian cancer as another modality for treating our patients. So essentially, HIPEC is heated intraperitoneal chemotherapy. And the thought is that hyperthermia, which is when you heat the patient and the chemotherapy up to actually pretty high, it's about 104 degrees, and you deliver the agent in the abdominal cavity. The thought is that it will enhance the cell kill and the ability to cause DNA damage of cancer cells and tumor penetration to thus, further increase cell kill. And the thought is that when you put it in the peritoneal cavity with the hyperthermia, you actually, especially we use cisplatin in GYN cancer, in ovarian cancer, is that the chemotherapy is better able to penetrate the cells with a very high level without the systemic toxicities as if it was given IV. So, this procedure is a procedure that's done by GYN oncologists. It's done right now in the operating room. Patients are, the procedure is indicated for patients who have stage 3 or 4 ovarian cancer. They got 3 cycles of neoadjuvant chemotherapy, and then they're taken to the operating room for interval cytoreductive surgery. And they're given HIPEC chemotherapy during that time. So the surgeons remove all the tumor they can see or feel, and then catheters are placed in the abdomen. These are long catheters, tubes that go to a machine. There's an inflow and an outflow, and the machine basically heats the chemo and it pumps it into the patient's abdomen and out. And what we do is we actually temporarily close the patient's abdomen. We do the surgery, put the catheters in, close the patient's abdomen, and then for 90 minutes, this cycle of infusion is going and the patient is being, the chemotherapy is circulated through the abdomen. And that's basically done with the hands of the surgeon, sort of massaging the abdomen and sort of allowing this chemotherapy to go through. This also is while the patient's temperature is rising. So anesthesia is very involved in this care of our patients, giving medications to make sure that the chemotherapy that's absorbed is flushed through the kidneys and making sure that the patients are comfortable and stable and continue to sleep under the anesthesia. Once the 90 minutes is over, we found that in cisplatin, you can get the proper levels that are advantageous for cell kill. In 90 minutes, the patient's abdomen is opened up. Again, the incision is opened up. the catheters are removed, and at that point, the abdomen is closed, or if there's any bowel resection that needs to be put back together, to join the bowel back up, that is done, and then the patient's taken to the recovery room. And this therapy was basically studied in a Dutch trial that was published in New England Journal of Medicine in 2018, that showed that these patients had a significant overall survival advantage and a progression-free survival advantage. The progression-free survival was 14.2 months, and the overall survival was 45.7 months with very little toxicities. But the important thing to know is that this trial was done really before PARP inhibitors were utilized, so much, which we'll hear more about later from my colleague, Dr. Richardson, bevacizumab and immunotherapy. So these patients didn't get any of those drugs, and they still had those advance. The length of stay for these patients in this trial were about 10 days, as opposed to patients that didn't have the HIPEC and only had the cytoreductive surgery was about 8 days. So, there's been another study that confirmed these findings essentially for this group of neoadjuvant chemotherapy advanced stage patients that was just completed in 2022.
Okay.
But, there are still some questions about this therapy because, we don't know exactly which agents to use, although we do use cisplatin now. There is some toxicity. The hospitalization, the hospital stays a little longer, maybe because of prolonged ileus, which is a slowing of the bowels. Patients feel nauseous. They may have just a longer, under anesthesia longer. It's a little more expensive. It's pretty labor intensive. So this is sort of, there's some controversy or some concern with these, and we don't know if the advantage to this that we've seen in these trials will be more or the same, or how would it interfere with, or maybe even complement those of PARP inhibitors, bevacizumab, and immunotherapy. So there's some trials that are going to be going on addressing all of those issues.
Okay, so it's still being looked at as in different potential ways. So it's still in clinical studies. That's interesting. Okay. Okay. Well, thanks for sharing that. We really appreciate that. I think that we do have some questions about that that have come in, and we'll get to that in our question and answer session. So I appreciate that.
Okay.
What about in the world of molecular characteristics? Is there anything going on there that you wanted to speak to?
Yeah. So, I have to say, I think one of the most exciting advances has been in biomarkers and molecular testing. Since the first genome was sequenced, this technology has really progressed in a way that has really opened up potential therapeutic benefits, and it's a really exciting time. We're learning more and more about these cancers, and especially in ovarian cancer, which we know ovarian, fallopian tube, and peritoneal cancer are all considered the same cancers, and they're treated, similarly, just because of the etiology of the cells are similar. So we used to treat all these patients the same. We put them on trials, and we treated them with the same chemotherapy. And then we were realizing that some patients did really well and some patients didn't do so well, and we weren't able to figure that out. But now with biomarker testing, molecular testing, and really comprehensive genomic profiling, we're starting to figure this out a little bit more. So essentially there's two types, right? There's a germline, or like a genetic one that you might have in your blood, or a saliva or a mucosal swab, which tests your genetic, the cellular abnormalities, the abnormalities in your genes. Whereas when we talk about somatic tumor testing, a biomarker is really testing the tumor itself. So for instance, this is really important distinction, because patients that don't have cancer, they might have a family history, really have genetic testing or germline testing, but patients with cancer often need both, right? So they need germline testing, the blood cancer that could be hereditary, or in some cases, and the somatic testings, which really determines, what is happening in their personal tumor itself. So that's why, for genetic testing or germline testing in the blood or the mucosa the slide, that it's really important to seek genetic counseling to ensure that the proper tests are done. For instance, now we do panel testing. Some people say, oh, I had genetic testing, 15 years ago and it was negative. Well, now we do panel testing. There's like 100 genes that, or 80 to 100 genes that, we test for. Because now, after the sequencing of the genome, we know that there's other causes of cancer that are outside of, say, BRCA and BRCA2, which are the most common, BRCA1 and BRCA2. And the other advantage of going to a genetic counselor is that, they follow up periodically, and they know the latest information on new discoveries on maybe some mutations that you may have, or some mutations that maybe we need to look into a little bit further, and what those ramifications are. So it's very important to have follow-up with a genetic counselor, as opposed to, getting the 23andMe for your Christmas and then, not knowing what to do with those results. This is an important information.
Well, thank you. Thank you so much for sharing that. It is indeed an exciting time, and an exciting time to learn more. And I think that leads us really a great segue into Dr. Richardson's talk for us. Dr. Richardson, can you speak to us now? Thank you for being with us. Can you speak to us now about a little bit about what's happening in the world of PARPs?
Sure.
Oh, great.
So thanks so much for the invitation. I'm really happy to be here with my excellent colleagues. And we just heard some exciting things from Dr. Villela. So to kind of transition then into PARP maintenance, which really does kind of segue well after talking about genetic testing and also about tumor testing. One of the more exciting things that was updated this year was one of the big trials that was done in the past was something called SOLO-1. And that was really the trial that established PARP inhibitor maintenance after frontline therapy for patients with BRCA mutations. And so for patients who have advanced ovarian cancer, who had a BRCA mutation, they were randomized to either receive the PARP inhibitor called olaparib or placebo. And what we found was that the progression-free survival, and so that's how long it is from the time that you finished your chemotherapy, started on that trial until the cancer grew back, was 13.8 months, so a little less than 14 months in the patients who got placebo, and was actually over 42 months in those patients who were got olaparib, which is obviously a whole lot better, right?
Yes.
And it's actually pretty shocking, because if you think about it, a lot of drugs will be FDA approved when they improve progression-free survival, say 4 months.
Wow.
We're talking about years improvement in progression-free survival with the addition of olaparib. And I'd also like to point out, it was basically 2 years of maintenance, with rare exception on that trial. If a patient did go on to that trial with residual disease, and at the end of the 2 years was still felt to be benefiting from the therapy and perhaps still had not gone into remission, then they were allowed to stay on. But almost all patients stopped olaparib maintenance therapy 2 years after starting it. So the benefit exceeds the length of treatment. And so they have now updated some of the overall survival data. And the really great news is that actually it's still not mature yet, which means that not enough events have occurred for them to know the final overall survival in those patients who got olaparib. So we do have the median overall survival now for patients who got placebo. It's 75 months. So that's a little more than 6 years. However, it still has not been reached yet at the 7-year mark for the olaparib arm. In order to consider, where we're at, we're probably got about another year or two before we're going to have mature overall survival data. But I will tell you, at 7 years, 67% of the patients who got olaparib we're still alive at 7 years, which is pretty awesome. Definitely an improvement. And we're hoping that means that actually the addition of olaparib maintenance to patients who have a BRCA mutation after frontline chemotherapy, and again, that's for advanced, so we're talking stage 3 or 4, we're actually hoping we will see an overall survival benefit, but we're just not quite there yet.
Yeah.
And basically in the patients who did get olaparib, it was on average about more than 5 years before they needed to start another therapy. So again, all really very exciting. I will just point out, because I think it's important, even though this is not necessarily brand new this year, there's still a lot of women who have advanced ovary cancer, stage 3, stage 4. And in general, when we're talking about this, we're talking about high-grade serous and high-grade endometrioid, just to kind of clarify that a little bit.
Sure.
There are multiple different maintenance regimens, and many patients are still not getting maintenance. In fact, about 25% of patients up front with a BRCA mutation still are not getting PARP inhibitor maintenance.
That many?
Yes.
Wow.
It's still
Wow.
pretty large. So
Wow.
we really need to move that needle. But the options for maintenance include bevacizumab. It can include a combination of olaparib plus bevacizumab. That's in general for patients who have homologous recombination deficiency. To shorten that, it's called HRD. That's a tumor test like what you heard about from Dr. Villela.
Correct.
And
yes.
in addition, if you don't have any of the biomarkers, niraparib is actually FDA approved for maintenance also. So you don't have to be HRD test positive in order to be offered maintenance therapy. It's just different benefits depending on what group you go into. And that's something you need to really discuss with your doctor.
Well, that's good to know. So you don't have to necessarily be HRD, I guess, positive to benefit from one of those drugs. Okay.
That's correct. Yep. So important that, you know, these tests are done, and then you have a conversation with your physician about where you're at, because these are for patients with advanced disease who had either a complete or partial response. So, you know, there are some various differences, and that's important that each person discusses that with their provider. So I think that kind of mostly goes to what's going on with the PARP. The only other thing I wanted to bring up is that just recently the FDA did move to restrict in the recurrent setting. So platinum sensitive ovarian cancer, which means that you have finished your chemotherapy up front and then the cancer did come back at least 6 months after your last platinum. That's what we call platinum sensitive ovarian cancer. For patients who, again, are on platinum chemotherapy and get a complete response or partial response, they have the option for PARP inhibitor maintenance. Until recently, there were 3 options, olaparib, rucaparib, and niraparib. However, the FDA just recently restricted both niraparib and rucaparib to patients who are BRCA mutated. So in other words, perhaps somebody was BRCA mutated and it was prior to the FDA approval of PARP maintenance in the frontline setting and then does recur. They can get any of the 3. Otherwise, olaparib is the only one currently approved for patients for platinum sensitive ovarian cancer maintenance. So that is a little bit of a shift recently. And it's really too complicated.
Oh, sorry, I didn't mean to oh, it's too complicated. I was gonna say, why is that?
Oh, it's so complicated
Yeah.
that we could spend an entire hour discussing
Okay.
that. I would recommend if people have questions that they discuss that with their provider, because I think it'll just confuse people if I try and explain that in a short time.
Okay, good to know.
And then did you want me to go ahead and talk about the antibody drug conjugates?
Yes, so we have a lot of questions coming in from the audience, and we've got some questions prior about wanting to hear more about the new recently approved drug Elahere. Is that how you say it, Elahere?
I think so.
I think
I call it Merv. I call it Merv or Mervituximab. So
Yeah.
yes, it's very exciting. That's a new drug that was just recently FDA approved. Basically, just to kind of back up a little bit, antibody drug conjugates have been around for a little while now in cancer, but this is the first one that's been FDA approved for the treatment of ovarian cancer. So there are about 13 FDA approved antibody drug conjugates at this time. Antibody drug conjugates are really interesting. They're a novel class of drugs. And essentially what they're trying to do is, it's like, I think about it like a smart bomb. So all of our cells have little proteins on their surface, and cancer cells often have different proteins than our normal cells. And so what they did was they realized a lot of patients with ovarian cancer overexpress the folate receptor. And so this drug then made an antibody to folate receptor. It has something called a linker. And then there's ultra potent chemotherapy, too potent to give untethered. And so it's delivered this way. What happens is then it binds to the cancer cell takes it up, then breaks it open, and then the chemotherapy is released directly into the cancer cell. And the idea is to hopefully reduce some toxicity and also get more effective cell kill. And so that's where the idea of the antibody drug conjugate comes from. And so this first one, Elahere or mirvetuximab or MIRV, is the folate receptor. And basically it was from the study called Soraya, which was presented at SGO in March of 2022. And so really interesting, I think we all learned that you can actually do a phase 3 trial and only have one arm. There are about 106 women that were enrolled onto that trial, and they all had to have high-grade serous ovary cancer. They could have 1 to 3 prior regimens of chemotherapy, and they all got mirvetuximab. They also had to have had prior bevacizumab, so all of them had bevacizumab in the past. The other name for that is Avastin, and about 50% had prior PARP inhibitor use as well. So this was relatively, representative of what the average person with ovary cancer now is receiving prior to going on trial. And the response rate was pretty promising. It was 32%. And so that beat the bar that they were expected to meet. And so because of this, the FDA did approve it. There is another ongoing trial, which has closed to enrollment, but we're waiting for the results of that. And that's called Mirasol. And what Mirasol did was it's a randomized phase 3. So it took patients and randomized them either to mirvetuximab or to investigator choice standard of care chemotherapy, one of 3 options, which are pretty standard, either weekly Taxol, topotecan, or pegylated liposomal doxorubicin, or what people might call Doxil.
Okay.
So that would be the confirmatory. In order to go on this trial, they did have to be high folate receptor positive. And what we know about that is about 1/3 of patients with high-grade serous ovary cancer are going to be folate receptor positive. And you don't need a new biopsy. You can actually use tissue from your original surgery to be sent. It's now been incorporated into one of the major, what we call next generation sequencing assays. So for people going forward, they'll have that information, but there are some companies now that you can send tissue to that will get results. And so you can start, we can start prescribing this medication. Sometimes insurance lags a little bit in trying to keep up with what's been approved. And on that trial, basically the median duration of response was almost 7 months. It was 6.9 months, which is definitely beats the comparator, or our historical, what we expect from chemotherapy. I just wanted to point out a couple of different things. I think a lot of people realize when you treat cancer, you can have nausea, you can have vomiting, GI side effects, diarrhea. But interestingly, mirvetuximab does have some eye toxicities. So one of the things that goes along with it is you do have to have an eye exam at baseline, and then periodically, and if you are having eye toxicity, it's important that that is addressed. And you have to use what are called lubricating eye drops every day. And then in addition, there are some steroid eye drops that are used around the time of the infusion for a few days. So yeah, it's a little bit different. We're not used to having to do those things. So
yes, good to know.
And then it can also cause that neuropathy, that numbness, tingling in the hands and feet.
Okay.
And then there's one more antibody drug conjugate I just wanted to mention, not yet ready for prime time, but it's a drug called upifitamab rilsodotin, or what you can call UpRi. And it just targets something else on the cell surface called NaPi2b. And NaPi2b is overexpressed in about 2/3 of high-grade serous ovarian cancer. And we presented that data at SGO, and that also had a over 30% response rate from the phase 1b expansion, which is an earlier trial than this data that we're talking about for mirvetuximab. But there is an ongoing, so for one thing, we finished our first phase 2 trial, which was the Uplift pivotal trial. And that's going hopefully for FDA registration. We'll see. We don't have the results yet, but hopefully we'll be presenting that this coming year. And then there's the confirmatory trial is ongoing, and that's a trial called UpNext. And that is for platinum sensitive recurrent maintenance. So for patients who get a platinum doublet and then have again either complete response, partial response, or even stable disease, which a lot of the trials in the past did not allow people to go on the maintenance trials if they had stable disease to the chemo. This one is. It's patients, if they go on this trial, have a 2-to-1 chance of getting the UpRi versus placebo. And then this also has a lot of fatigue, you can get some dehydration, nausea, vomiting, side effects that I think are manageable, but can be worrisome to patients, but we can often get people through with supportive care. So a lot is happening right now in ovary cancer and pretty exciting.
Yes, absolutely. Hearing you talk about these new proteins and things on the surface of cells that we're smart enough to now target is just really, really exciting. So thank you for sharing that. Thank you for sharing that. That's wonderful. Awesome. Well, let's move on to Dr. Chu. Thank you so much for joining us today. And I wanted to ask you specifically a little bit more about the world of some more rare ovarian cancers, what's happening in that world, and maybe specifically those that are diagnosed with low-grade serous ovarian cancer. Is there anything that's going on there, any progress being made there in that area?
Sure. Well, again, I would just want to thank you for giving me this opportunity. This is just a great forum and some great colleagues here to have a chance to discuss these things. So thank you. So a little bit about low-grade serous cancer. As I'm sure much of the audience knows, this is a rare type of ovarian cancer. These tend to happen, these only comprise about 5% of all epithelial ovarian cancers. These tend to happen to younger women. And overall, the survival for low-grade serous cancers is better than for high-grade serous ovarian cancers, but they tend to be very chemotherapy resistant. So there was a study actually reported in February, I believe, of this year, looking at showing that hormonal therapy may be a good option for these patients. We know that because there are a couple of trials that are ongoing now. There's one in the United States that's sponsored by the GOG or Energy Oncology that's in progress for patients who have undergone surgery for stage 2 to stage 4 low-grade serous ovarian cancer, who should get surgical debulking and then chemotherapy afterwards. But because we know hormonal therapy is very promising, most of these patients express estrogen and progesterone receptors. The patients are being randomized to either getting the usual carboplatin and Taxol for 6 cycles, and then maintenance therapy with letrozole, which is an oral pill that's an aromatase inhibitor that basically blocks the production of estrogen in the body, or just the hormone blocker alone, just the letrozole alone. And so that's a trial that's in progress. I think is very interesting to see because we know that the cancer is chemotherapy resistant, whether we can spare women the effects and the side effects of chemotherapy and just give hormonal therapy. So we're eagerly awaiting that. A similar trial is going on in Italy as well. But the study that I referred to previously, it was reported in February, looked at how to treat patients with recurrent low-grade serous ovarian cancers. And this was a study that looked at, it was a phase 2 to 3 study, and patients were randomly assigned when they recurred to either standard chemotherapy, which could have been Taxol or Doxil or topotecan, with a drug called trametinib. And trametinib is an oral pill, and it's a targeted therapy, and it works to inhibit some receptors called MEK1 and MEK2. And these are cell signaling pathways. So it's, again, specifically targeted to these areas. This study treated, it was quite a large study. There were 130 patients in each group. 130 patients got the oral trametinib and 130 patients got more traditional chemotherapy. And while there was no difference in how long people lived in overall survival, the progression-free survival was almost double in patients who received the oral trametinib. So they had a progression-free survival of 13 months versus only 7 months on the chemotherapy arm. So that's very promising. So at this point, I think that for people who recur, trametinib is a great option other than chemotherapy. The other sort of more rare tumor that I wanted to focus on just a little bit was clear cell cancer of the ovary. So clear cell cancer is also a rare subtype of epithelial ovarian cancer, also tends to be very chemotherapy resistant. Patients, tend to be younger when they're diagnosed, and they tend to be diagnosed at earlier stages. There is some association that we know with endometriosis, which may be a condition that many women in the audience are aware of. So, we know that these patients, we know these patients tend to be resistant to traditional chemotherapy, but right now, the recommendations really are to treat them similarly to other subtypes of epithelial ovarian cancer. So patients who have advanced disease will get treatment with something like carboplatin and Taxol with a platinum and a taxane regimen. But there was also an abstract reported at ASCO this year that a very large study was done in Japan at 7 different hospitals where patients with advanced disease got initial debulking surgery, and then everybody got chemotherapy with some kind of platinum and taxane, and some got chemotherapy. They compared patients who got chemotherapy with Avastin or bevacizumab and those without. And there were 102 patients who received treatment without the Avastin and about 42 patients who received treatment with the Avastin. And again, there was an improvement in progression-free survival. So patients had longer remissions or longer time before their disease progressed if they got the bevacizumab. So that was promising as well.
And that was for clear cell cancer?
That was right? Clear cell cancer.
Okay. Right. Okay. With the
so,
bevacizumab.
Yeah. So sort of slow incremental progress for these cancers that are traditionally difficult to treat.
Sure. Yeah. Well, thank you so much for touching on that. And thank you all I know this is our Ask the Experts is a fairly quick program. We've tried to pack as much as we could into the 30 minutes, but we do have about 15 minutes now for some questions. If you guys are up for that, we have a few that have come in. And specifically, the first one was about the drug Elahere. And I think Dr. Richardson, you already answered that. The question was, do you need to have your tumor tested again? But I think you alluded to that you could use your previous tissue sample. Is that correct? Yeah. Okay, perfect.
Yeah, that's correct. If you didn't have any tissue for whatever reason available, you certainly could have a fresh biopsy to be tested. But if you have tissue, which most patients with ovarian cancer are going to have tissue, they can just send tissue that's in the pathology bank.
Great. Another question along those lines is also, let me see here. How does the new folate receptor alpha target, if I said that right, for Elahere, change treatment algorithms for PROC patients? I'm not sure I know what that is, but
so somebody is savvy out there. So PROC,
yeah, very savvy.
platinum-resistant ovarian cancer.
Oh, platinum-resistant ovarian cancer. Okay.
Yeah, so I think it's just one of the options. I think just, basically we have multiple options. I do think if you meet criteria to be treated with mirvetuximab, your high-grade serous with high folate, I probably would use that over some of the other things because I know what your response rate is likely to be. So again, we're waiting for that confirmatory trial, but I always would love to use a biomarker driven treatment over just a treatment that may or may not benefit somebody. So I would definitely prefer if I can say, yes, you have the high folate, I'm going to offer you mirvetuximab, assuming that there's no contraindication to it.
And remind me, you said the confirmatory trial for that was called Mirasol, is that correct?
That's correct. So right now the drug is FDA approved, but it's accelerated approval, which means that the FDA will not grant full approval until the results of Mirasol are available, and they are not available yet.
Okay, that's good to know. Okay, cool. Regarding HIPEC, I think for Dr. Villela, a question came in about, let's see here, about maybe the long-term benefits, and you may have already spoken to this, the increased progression-free survival. I think you did touch on that. Does it outweigh the increased complications after surgery? Someone had mentioned that it seems like sometimes hospital stays might be much longer, but I think you touched on that as well, but you want to address that a little bit?
Sure. I think, when you do HIPEC and you're planned for HIPEC and you're doing an interval cytoreductive surgery, which you've gotten chemotherapy, a few cycles, usually 3, then you go to the operating room. It's a big surgery. I mean, it's multi-organ. Many times there's a long operation with a lot of specimens. And in these cases, patients just from that already have a little bit more complications. However, the HIPEC in the study, between the two groups from the Vandriel study, which was the Dutch study published in 2018, New England Journal, those patients had a 10-day hospital course as opposed to 8 days. And that may also be because you do see some renal insufficiency or kidney dysfunction, which means that some of your blood numbers, like your creatinine, could bump up a little bit just because of the toxicity of the cisplatin. So those patients may be in the hospital, getting fluids or sort of watching their renal function. So the actual toxicity in terms of poor outcomes really has not been shown to be that much worse than, just it's really the surgery more than the HIPEC itself.
And can you clarify in regards to HIPEC? I think there's some questions among those that are listening or those that are watching right now. Do you still need traditional chemotherapy in conjunction with HIPEC?
Yeah, so this is
confusion that you do not.
Yeah, this is actually a great question, and I'm really glad that someone raised it. This is always a savvy group on NOCC. So, so yes, you do. So for ovarian cancer, the surgery, the chemotherapy is given 3 cycles up front. Some people get 4, but mostly it's 3 based on the study. Then they get the intraperitoneal chemotherapy with HIPEC in the operating room. And then about 4 to 6 weeks later, they start giving the last 3 system, IV cycles of carboplatin and Taxol, and those are given, once every 3 weeks. The difference that we don't know, and I think this is a really important point, is now with the knowledge of how well PARP inhibitors work in mutated patients, somatic mutation patients, HRD with bevacizumab and PARPs, and immunotherapy based on our biomarkers. We don't know if the HIPEC will still have that survival advantage, or if you could exchange HIPEC for a PARP inhibitor, bevacizumab maintenance, and that's, I think, the question that's going to be answered on the next, these trials that are ongoing now.
Yeah, for sure. Absolutely. And one other thing on HIPEC, could you clarify whether this procedure specifically is used for those with early stage or only advanced stage ovarian cancer?
So that's a very good question as well. It's for advanced ovary patients, advanced ovary patients at this time, yes.
And you would consider that stage 3 or 4?
Correct.
Okay, great. Thanks for those answers very much. Going back to PARPs, maybe anyone really, but Dr. Richardson, what factors beyond genetics determine if a doctor will put you on a PARP? Are there any other factors beyond genetics that can determine that?
Yeah, so I think I alluded to this a little bit, but maybe to try and simplify it. Essentially, if you are newly diagnosed advanced ovarian cancer, and again, this is mostly high-grade serous or endometrioid, if you are not a germline BRCA patient or don't have a tumor test positive for BRCA, then you can be put on a PARP inhibitor for maintenance, niraparib, irregardless of what your germline and tumor testing is, or you can be placed on olaparib if you are HRD or BRCA. So really that's, and then also, I guess, to answer the question, it's your response to chemotherapy as well. So you have to have a response to chemo in order to get PARP maintenance. And then otherwise, if we're talking about recurrence, then it depends on where you're at. In general, PARP inhibitors really are not being used for treatment at this point. They're mostly being used in the maintenance setting. There might be some few exceptions for patients who may find themselves that they were BRCA mutated and had their original diagnosis a long time ago prior to PARPs being available, and then have some, had a late recurrence and had not seen a PARP. You might see a patient like that be treated with a PARP. Other than that, it's mostly going to be used in the maintenance setting. And so then it comes down to if you're platinum sensitive, and you have a response to platinum, because actually the number one thing that's going to predict PARP efficacy or it working is either BRCA mutation and your sensitivity to platinum.
Okay, good to know. I think another question that kind of maybe follows along with that is, one of the questions we get a lot is, besides BRCA1 or BRCA2 or HRD, are there any other actionable mutations that can help determine what type of treatment someone should have, or maybe that are in study right now?
Well, I could defer to some of my colleagues as well, because Dr. Villela kind of talked about genetic testing, but actually there are some of the other germline mutations do fall in that pathway of homologous recombination deficiency. So, there are some germline or, again, tissue mutations, like, for example, RAD51 is another one that,
heard of that one.
If anybody on this, has one of those mutations or not, but, she mentioned that there are other mutations. And so the short answer is yes, there are things beyond BRCA1 and BRCA2, and I don't know if you want to say anything else.
Yeah, I just want to say that that's part of the advantage of doing the somatic testing or the tumor testing with the, next generation sequencing or the genetic profiling, the CGP, sometimes you hear as CGS, all these, yes, alphabet soup here, but that's basically looking into the tumor. So what we're trying to do is maybe hear of personalized medicine. It's not really, that's like an overutilized term. And really what it's referring to is getting everything from you, your genetic test in your blood or your saliva or your gene testing and your tumor testing and putting it all together and saying, are there any targets here that may work better? Now, there's going to be, when you test tumors, you can come up with lots of things. Some of them don't have any, drugs or they're not therapeutic targets yet. Some of them may not be important drivers of the cancer, so it's not worth treating that. But things like HRD, BRCA mutation, loss of heterozygosity, macrosatellite instability, these things are more actionable and they are really the ones that we're currently looking at. But, the more data we get, that's why, and we're trying to do this more upfront now, as you heard Dr. Richardson say before, using some of these agents sooner rather than later, we think may actually be more important. So that's been a big shift.
Absolutely. Absolutely. Good. Thank you.
And then I guess just to add to that, it also helps us because I think all three of us do participate in clinical trials. That testing is so important because I can often match patients to trials based on their tumor testing.
Absolutely.
As far as novel agents where, you can't get that unless you're participating in a clinical trial.
Absolutely. Dr. Chu, a question came in regarding one of the more rare cancers. You had mentioned a little bit about clear cell, and we're often asked why it's prone to younger females. Is there any theory about that or anything that you know of why it may be more prone in younger individuals than older?
I'm not sure that I know the answer to that, except that it does seem to have some association with endometriosis, which tends to be more active in premenopausal women. But I would not, and maybe my colleagues know of any particular mechanism for why that arises, but I'm not aware. I just know the association.
Sure, with the endometriosis and premenopausal.
Right. I'm not sure that I know reason for cause.
Sure. But that association, I guess, would kind of make sense. We get asked that question a lot too, Dr. Chu, is what's the relationship, or is there a relationship between endometriosis and ovarian cancer? And that's very interesting to know. So, okay, well, thank you for answering that. Let's see here. Let me see. I think there was another few questions that came through. We've got about maybe 5 more minutes. Oh, here we go. So another one back to PARP. That's a pretty popular topic. How long should a patient give a PARP inhibitor to work, even if someone's CA-125 is rising? I don't know if that's a question that we can answer, but.
So I would, these are always really tricky questions, but basically I think all of us would probably agree that you look at the person as a whole and not just one thing. So the CA-125 is one thing, it's a marker, but there's also imaging and there's also physical, exam and also symptoms and how somebody is doing. And so I think all of that needs to be taken into account. At least when I'm, managing somebody, I don't typically give up on a therapy, for example, or stop a therapy based on CA-125 elevation alone. I don't know if Dr. Chu or Dr. Villela have anything else to add to that.
Yeah, it's just one part of the whole. Yeah, absolutely.
Yeah, I agree. And the only other thing about PARPs that I would say is that if someone hasn't had a PARP, they should really be considered for a PARP and just make sure that they ask their doctor if they're a candidate, because I think that is a really important point.
Yeah. Another question about genetics, which has been asked more than once here, is you had mentioned, I think maybe Dr. Villa, you mentioned in your at your talk at the beginning, was how often genetic testing changes, how much more we're learning. And so the questions that have kind of come through are kind of asking the same thing, is how often maybe should someone who's had genetic testing, maybe do they need to be tested again, or do they need to be at all?
Yeah, I think if someone did not have panel testing, so it's really important to make sure you know what you were tested for. So you want to see the report. You want to know what lab, when, because now, like about, in the past 10 years, we now do panel testing. You want to make sure you had a panel test. Your family history may change. You have to constantly update family history and reach
True.
out. And I can't underscore the importance, I think, of involving genetic counselors, because they're really on top of this. And you're a GYN oncologist, very important. A lot of people are doing testing outside medical, without medical supervision. And while that's been maybe good in some ways, it also, you don't want to not know. Sometimes there is variants of undetermined significance 10 years ago, and now we know what that variant is. There it is, or maybe it isn't significant at all. So there's no reason to worry. So these things are really important to know exactly what you have. And also, if a family member of yours has a germline, which means that's hereditary or something that's in their blood, not in the tumor, that can be hereditary, but it doesn't mean they're 100% going to have it, So I think there's a lot of unnecessary worry and anxiety on patients, and also when to test. I mean, there's question or really when you need to test patients. Patients need to be tested, usually, about 10 years before the youngest person who had the cancer. But I mean, these things change. It depends on your family history. See, there's really no blanket rules. It's really very important to just have some medical guidance.
Yeah, absolutely.
Can I just add one thing? Just because I think sometimes people have the impression that if they had 23andMe and they had a BRCA negative test, that a medical doctor does not in any way consider that to be an adequate test. The 23andMe testing only includes 4 mutations and not the plethora of other very serious pathogenic mutations that are out there. So if you're someone who's had a 23andMe test and it said you were negative for a BRCA mutation, if you have a concerning family history, I would just beg you to please see a genetic counselor and have formal testing.
Yes, thank you for mentioning that very much. Yeah, absolutely. Well, believe it or not, we are at our mark. There are maybe a few other questions that we can definitely make sure that I have our panel, if they're willing to answer some questions for us offline, we can definitely get those questions answered and sent back to you. But I just want to thank you so much, all of you, for joining us today on our program. And your information is invaluable. It's very helpful to our community who comes to us looking for answers. So we appreciate your time today in joining us, and thank you very much.
Thanks.
Thank you. Take care, everyone.
Thanks so much.